Welcome to Cardiology 101. This is Dr. Nicholas Hodgman. We're glad you're with us, and if you're watching a recording later, we're glad you're listening to us. Today we're talking about heart racing and palpitations and what they mean and some heart rhythm issues. These are commonly seen in cardiology clinic, and hopefully we can answer some of your questions today, and appreciate you joining with us. This is what we'll cover today. We'll talk about the electricity of the heart. We'll then talk split up heart rhythms and extra beats, split them up between the top part of the heart and the bottom part of the heart. There's a big difference when an abnormal heart rhythm comes from the top of the heart or the bottom, and we'll be talking about that. Here you can see if it comes from the bottom part of the heart, that's not a good thing. If it's from the top, it's less concerning. We'll then talk about other things besides heart trouble that can cause bad heart rhythms, and we'll talk a little bit about treatment. So the heart is an amazing organ and is smarter than one would think. If you look at this picture here, those green lines represent circuits that are in the heart that carry electricity through the heart. The top chambers are located obviously at the top part of the heart. You can see there's two green nodes there, one called an SA node, the sinoatrial node, and one called the atrioventricular node. Now these are not circuits, they're little electrical stations that are in charge of doing different things electrically. The goal, of course, is having the heart top chambers beat and pump blood into the bottom chambers, and then the bottom chambers following the top ones and squeezing blood out to your body into your lungs. I'm going to see if I can get a mouse here to show up. So here, right here in this, what we call the SA node, is where the electrical activity of the heart starts, and it's in charge of controlling and continuing. We'll go back into our other mode here in a second. Just need the mouse here. And the electrical circuit kind of spreads across the top part of the heart, and then before it goes to the bottom, it has to go through this little electrical station called the AV node, which slows it down so that the electrical signal doesn't go too quick and cause the bottom part of the heart to pump while the top part of the heart is still pumping blood into the bottom. That wouldn't be good. No one would feel good that way. So very organized pattern. Again, the top part of the heart electrically is separated from the bottom part of the heart by this special node, which is a mass of special tissue that's in the heart that's in charge of slowing the electrical signal down and getting it down to the heart through these middle electrical circuits. These are, of course, specialized tissue, not real metal circuits, of course, and this is how the electrical system works. So always starts here, goes across the top, slows down here, then goes to the bottom, so that the top chambers pump, and then the bottom chambers pump. So what we measure, these are two examples of electrocardiograms. That's where they put the leads on the outside of your chest, and we can pick up electricity from the outside of the body on the chest wall. We pick up the electricity that's passing through the heart muscle. It's important to note that we cannot pick up the electrical activity of the actual circuits. All we see is the electrical activity of the muscle contracting. And so here's a basic EKG, top and bottom. Here's a split down. We split up these electrical waves into letters, and that helps us know where they're coming from and different things that can be wrong. This is a normal-looking EKG here, as well as this. The P wave represents the top part of the heart here, electricity passing through the top part of the heart, small. The large wave is the electricity passing through the bottom part of the heart as the heart muscle squeezes. So this big wave right here, as you can see here, this big wave here, the big tallest ones, are when the bottom chambers are squeezing and the electricity is passing through them so they can squeeze. This T wave is when the electricity resets itself and the heart stops pumping you get a signal, electrical signal, as it goes back to normal and back to normal. Then it starts over again. P wave, that's the electricity going through the top part of the heart. Small because there's not a lot of heart muscle in the top part. You can see thin walls here. The middle wave, what we call the QRS wave, is the wave through the bottom part of the heart. You can see there's a large electrical signal because there's big, thick muscle down here, and that's what the EKG picks up. So again, here's a normal EKG, nice and regular on a patient who has a normal electrical system, and looks good. So we'll just do a quick quiz before we teach anything, just to see if we have anybody smart out there. Do you have a chest up there? So, quick question. So, anybody that's joined in, is the top one normal? Which one's abnormal? This is starting out real easy. Top or bottom? So, let's correct. The bottom one is abnormal. You can see here that this is our normal EKG, where we see a deflection from the bottom part of the heart. Here's the top part of the heart. Here's that extra wave as the bottom of the heart resets. And here you can see we have a normal tracing here and then some abnormal tracings here, which we're going to talk about. So we'll initially start talking about fast heartbeats and extra heartbeats from the from the bottom part of the heart. That's this part here. That involves the largest wave, and these are the most dangerous, and that's why we're going to talk about them first. So the most dangerous is called ventricular fibrillation, and we'll kind of spell this out for you. Ventricular just means the ventricles. Those are the bottom chambers of the heart. Atria are the top chambers, so the ventricles are the bottom chambers. Fibrillation means to shake. And so this rhythm that you can see here looks very unorganized and chaotic. That is just sporadic electrical signals all over the heart in a non-organized way, not in the circuits of the heart, which cause the heart muscle of the ventricles, the main pumping chambers, just to shake. They never squeeze. It's bad. It's very bad. You cannot survive with this. You're not even awake a second. If you go into this for a second, you pass out because you have no blood pressure. No blood gets pumped to your brain or anywhere. So this is a deadly rhythm. It's uncommon, thankfully, usually caused by heart attacks. This is why, as we've talked in some of the webinars in the past, we have what's called an AED in airports and schools and a lot of public places now. This AED, which is a defibrillator, emergent defibrillator that anyone can use, just got an easy push button, stick the pads on, follow the directions that it'll talk to you about. You push the button to shock people out of this. And that electricity given through these pads resets the heart so it can start back up normally where it normally starts up here and spread normally through the circuits. There are some rare other causes besides heart attacks for this rhythm. It can be in young people, but it's extremely rare. And again, this is a deadly rhythm, and always the only way to treat it is always to give the patient a shock, either with paddles or with this external defibrillator, automatic external defibrillator, which provides an electrical shock between these two to reset the heart electrically and have it restart over the way it should. The second dangerous heart rhythm from the bottom part of the heart is called ventricular tachycardia. Again, the ventricle is the bottom part of the heart. These big chambers on the bottom. Atria are on top. Tachycardia just means fast heart rhythm. So this is, in normal language, means a fast heart rhythm from the bottom part of the heart. We call it short, VT, in the medical profession. It's fairly uncommon. It looks like this on the EKG. People have a normal rhythm, and then they have what looks like shark fins or, a rapid, regular, wide tracing there. And you can see this is abnormal. You don't see the normal tracings on the bottom. This is uncommon, often is triggered by something. Someone can be sick. Someone can be having a heart attack. Someone can have the chemicals in their body out of whack. Sometimes it can rarely happen just on its own. This again is dangerous. People usually will pass right out. It does not, because the heart does not work well enough for you to stay alive and walking around when you're in ventricular tachycardia. Once in a while you can get someone that can tolerate it, but no one feels good when their heart's going this fast and it's only beating in this bottom chamber. This picture here shows what's happening electrically. Instead of coming down the signal pathway and spreading across the heart like it should, it's an electrical signal in one little spot in the bottom part of the heart that just kind of is perpetuating itself. Let's see if we can get my mouse back here. Okay. One of the most common things we see and a lot of people have experienced is when they feel an extra beat or a palpitation in their chest. And commonly this can be caused from what we call a premature ventricular contraction. So let's break that word down. Premature means early. Ventricular means from the bottom part of the heart. And contraction means the heart is squeezing. So if you look here, we have a normal rhythm, and then all of a sudden we have this weird-looking wave that's happened in a patient. And this is the electricity of the heart going through normally the heart muscle, then all of a sudden an abnormal electrical beat. And in this case, it comes from the bottom part of the heart. That's why it's called a premature ventricular. Remember, the ventricles are in the bottom. Ventricular contraction. And so what happens is people feel the heart muscle, they feel their heart beat out of rhythm, and they feel this big extra beat. And typically what they feel is not really this, they feel the next one. Because when the heart has this extra beat from the bottom, it doesn't squeeze well, and so the very next beat, when it resets, is an extra large beat to compensate, to make up for the poor beat prior. So people feel kind of a pounding in the chest, or what we call palpitations. These extra beats, and sometimes beats that feel really hard or large or powerful beats in the chest. Extremely common and often triggered by something else. So there is a couple of different reasons we'll talk about what triggers these. Some people just have them. Just from birth they'll have them, and we can talk about what treatment. Some, more commonly, they're triggered by stimulants like caffeine or other electrolyte problems, if the potassium's too high, low, things like that. But extremely common and not dangerous. Now, they only would be dangerous if you've got multiple PVCs, as we call them, premature ventricular contractions, these extra beats from the bottom of the heart, if you had multiple in a row. And of course, if you had multiple in a row, it actually would be ventricular tachycardia. And so you would not feel well. One would not feel well if they had those. All right, let's take a quick pop quiz. So let's say you're walking in the urgent care and no one's around, and you see this rhythm up on the monitor. You see a normal beats, and then all of a sudden you see these squiggly lines, and the patient stops talking to you. No one's around. I guess my question is, A, do you call for help? B, do you shock the patient? C, do you try and arouse the patient? So this is, you would initially always call for help unless you knew how to shock the patient. This is a form of ventricular fibrillation. We know because the waves are big, so it's bad. That means it's coming from the bottom part of the heart. Anytime the waves are big, it's bad. Bottom part of the heart, and they're wide and irregular. And this is ventricular fibrillation in a specific type that requires you to shock, or the patient just won't make it. So you'd call for help and shock. They're both the right answers. Let's see if we can do another quick quiz here. So do we think this heart rhythm, these extra beats here, are from the top part of the heart or the bottom part of the heart? So if you look carefully here, This is a normal beat here. Now this is a large extra beat, which is from the bottom part of the heart. And then we have a normal beat, nice and narrow, just like in the beginning. And then see how wide it is and big? These are from the bottom part of the heart. So we're getting a run of 3 bottom beats that are kind of out of line. And then over here we have a whole full run. So this is ventricular tachycardia from the bottom part of the heart, a dangerous rhythm because it's from the bottom part of the heart. All right, let's get going and start talking about fast heartbeats from the top part of the heart. There's 3 major ones. There's many more that you could break down. These are the 3 most common we'll talk about today. First one we call SVT, which stands for supraventricular tachycardia. Second, atrial fibrillation, fast and irregular. And third, PACs, which are premature atrial contractions. We'll talk about each one of these. So let's first talk about SVT. SVT stands for supraventricular tachycardia. And you can see here, the ventricle is there. That's the bottom chamber. Super means above. So now, instead of just saying, doctors have to be complex. So instead of saying heart rhythm from the top of the heart, we say supraventricular, above the bottom of the heart. So this rhythm is from the top chambers, SVT. Tachycardia, again, means fast heart rhythm. So SVT is a fast heart rhythm from the top part of the heart. It's very common, usually triggered by something. We'll talk about triggers. Not dangerous, can't die from it, and can usually, many times, be self-treated right at home. And we'll talk a little bit about that. So let's look over here. You can see here that what we see is the wave. There's a little waves in between these big electrical waves. They're not wide. When they're wide, it usually means they come from the bottom. When they're narrow, it means the fast rhythm's coming from up here and using the normal circuits. If electrically the normal circuits to the bottom of the heart are working, then you get a nice narrow, big wave. So we know then, it's a little complex, we know if the wave is narrow and not wide, like we saw, say, back here, wide, see how much wider it is than this one? Wide, narrow. We know that in this wave here, it's going through the proper circuits. In this wave, something's not right. It's not going through the proper circuits. And so when you look at this rhythm, you know that the bottom part of the heart is working okay because it's narrow. So then why is it so fast? If you look how fast that is, that's almost 200 beats per minute. So this person is beyond running a marathon here. Very fast. We know that fast rhythm is coming from the top part of the heart. And you can see here SVT is when there's a circular electrical problem in the top part of the heart. Just kind of generates itself. It's ignoring the normal node we talked about that's in charge and just generating its own out of control fast heart rhythm. But then it's passing through the normal circuits in the bottom part of the heart. That's why it's not dangerous, because the heart will continue to beat. Now, people will feel bad when their heart's going this fast, but they won't pass out and they won't die. One thing that can help control or break this rhythm is what we call a Valsalva maneuver, or a bearing down. There's a lot of nerves that are attached to the heart, and in particular to this node here. And your brain controls your heart speed by communicating with these 2 nodes, through nerves. And so, you can sit yourself down and kind of talk your own heart rate down. That's because your brain is connected to your heart, and your heart is smart and gets those signals and can slow right down. And of course, when you exercise, those electrical signals can cause the heart rhythm to speed up. Now, in this, you can, if you bear down and kind of press down in your abdomen and kind of hold your breath and bear down, you can send a strong signal to slow down your heart, and sometimes will break this rhythm right at home. So people who suffer from SVT, oftentimes they know that they can do certain maneuvers to break it at home. They don't have to come to the ER. We'll talk a little bit more about treatment later. Atrial fibrillation, very common. Sorry about the mouse here. We'll just use it in this version here. Atrial fibrillation is very common, especially among elderly patients. and people, and it's not deadly, but it can be annoying. You have a stroke risk with atrial fibrillation. We'll talk a little bit about that. It can cause people to not feel well, and sometimes you don't ever know if you're in it. And we're going to have a full webinar on atrial fibrillation, but we'll talk a little bit. That's how common it is. That's why we're having a full another discussion on it. But let's talk just a little bit about what it is. Now you see here, normal electrical system of the heart starts in the sinus node, the specialized little power factory that starts our heartbeat. Electrical signal travels across the top chambers, then goes through the circuits, and then goes through the bottom part. That's what gives us this nice regular beat. And you can see here in atrial fibrillation, it's completely irregular. And we lost this, what we call the P wave. Remember, the P wave represents the electricity going through the top chambers of the heart in an organized fashion. Here we have no P waves, we just have a bunch of squiggles, and then we have irregular, large waves from the bottom part of the heart. So if you look here, atrial fibrillation, the atria are the top chambers. That's why we call it atrial. Fibrillation means to shake. We talked about that. So in this case, the top chambers are just shaking. Electrical signals, unorganized, going in little circles everywhere, and they don't squeeze. They just sit and shake. And some electrical signal gets through, albeit irregular, and causes the bottom heart to pump normally when a signal gets through, but it's going to be irregular. So some people can feel when they're in this rhythm because their heart rhythm all of a sudden is not regular. They also sometimes don't feel well. People complain of being tired or feeling their heart race, and there's about 100 symptoms, but those are the two major ones. Now, why can it sometimes be silent and people don't die? Well, remember, it's the large pumping chambers in the bottom that we care about most. And as long as those are pumping, and you can see these big waves here that the bottom chamber is pumping, it keeps people alive and feeling okay. The top chambers are less important. So this is not a rhythm that needs to be emergently shocked, even though the word fibrillation is in it. Of course, if it said ventricular fibrillation, that's an emergency. So we'll talk more about that. Another very common finding and a reason for palpitations or extra heartbeats that people feel are from what's called PACs, a premature atrial contraction. So you can see here we have an extra beat here. So if you look, we have a normal electrical beat, and then another normal, and then one that looks like it came in early. Here's normal again, normal, 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 oh, and there's an early one. So this is kind of this what we call a PAC, or a premature atrial contraction. Let's just break that down. Premature, of course, means early. Atrial means top chambers, so this is the top part of the heart problem. Contraction is squeezing, so this means the top part of the heart is squeezing earlier, too early, out of order. So what's happening here is you're getting an extra signal that's not part of the circuit in the top part of the heart that's just trying to take over. It's being obnoxious, trying to get in early, doing its own thing, and not following the right order. So here's normal beat, early. Now some people feel these. Many times people won't ever know these happen. You can have a lot of these. And if you have a lot in a row of premature atrial contractions, what would we call it? If you had a whole bunch of premature atrial contractions in a row, fast. That's kind of a tough question, but we covered that. That would be called SVT. Remember, a spot takes over. Instead of just one, you get a whole bunch of them, and it never really comes out. Whereas in this patient, they just had one, and then kind of snapped back into a normal rhythm. The electrical circuits took back over again. So they're not dangerous, triggered often by stimulants, again, caffeine, and other things we'll talk about. And these also can be a cause for palpitations. One thing that's important to note as we talk about these basic heart rhythms is that the heart is an organ like anything else. So if there's something wrong with the body or some chemical has been brought into the body, the heart reacts just like everything else. So for example, someone who, maybe kidney failure and our electrolytes are out of whack, or they're dehydrated and their potassium's too high or low, or not enough calcium. That directly affects the heart muscle cells and can cause heart rhythm issues. Also, a big issue, especially that I see multiple times per week, is an overuse of caffeine. This is not your typical coffee, tea drinker. This is more the energy drinks and 5-hour, all those things that have come out in the last 5 to 10 years that have gotten some of our young people in trouble, who come in with palpitations, and they're having 4 to 5 pretty heavy duty doses of caffeine throughout the day, and that's a direct stimulant to the heart, also an electrical irritant to the heart, especially at high doses, and so people can have extra beats, TBCs and PACs from caffeine. Another common one is the thyroid. The thyroid has many effects on the heart as well as every part of the body. And if your thyroid, which is located in your neck, is not working correctly, either producing too much thyroid hormone or not enough, this can directly affect the heart and cause heart rhythm issues. So your doctor, if you go to your doctor and complain of heart palpitations, they should always be checking your thyroid. If not, the cardiologist will definitely check it as well. Again, any other illness can affect the heart. Some people that are infected with some large infection or very sick, the heart will also display heart rhythm or abnormalities. And, of course, heart attacks is a major one on the list. If the heart muscle is irritated from a heart attack, meaning it's not getting enough blood, it can be electrically irritated and cause bad heart rhythms. Initially, if you're seen either by your primary care doctor in the ER or by a cardiologist, the first thing they'll do is, besides get a tracing and look at what your heart rhythm looks like, they will often check labs to make sure, like we talked about, your potassium, calcium, and electrolytes are normal. Make sure you're not having an infection. And they also will recommend, of course, that you would stop any stimulant and hold caffeine and any other stimulant to your body. Often these can be caused by sinus medication with amphetamines is also a stimulant, which can cause heart rhythm. Also, everyone who has kind of a persistent heart rhythm issue should have an echocardiogram, which of course is shown here to the right. It's an ultrasound of the heart, and basically it allows you to see the heart structure. And there are some cases that people will have heart rhythm issues because the structure of their heart is not normal, either from birth, a birth defect that they may never have known about, or from a heart attack that they never knew they had. And so it's important to get an echocardiogram, an ultrasound of the heart, to evaluate whether there's a structural reason for the heart rhythms. First off, usually a treatment for almost all of these rhythms, except for the ones that need to be shocked immediately, initiation of beta blockers is done. And I've given you a list here of beta blockers. Beta blockers are a specific kind of medication that act directly on the electrical system of the heart. And we can look over on the right there. You can see it affects the SA node, which is in charge of initiating heart rhythm electrically. It basically blocks adrenaline from the heart, so it's basically an anti-stimulant. Sometimes your body can make its own stimulant in the form of adrenaline, and a beta blocker will block this, and it slows down and calms the heart and calms it down electrically. This pill alone will solve about half the rhythm problems that people will come to clinic or to the ER with if they take this at home. And often, people don't need to be on them for life. There's some major ones listed on the left there: Lopressor, Toprol, Bystolic, Coreg, Atenolol. Some cheaper, some newer, some more expensive. All work fine. They do, of course, with every medication, come with some side effects. Usually in young people, they'll notice they're a little more tired than they should be. And I'm sure there's a list of about 50 million other things, but most complaint we see is fatigue and tiredness from being on beta blockers, of which most people, if they need to take them long term, will get used to it and kind of adjust, and they don't notice it after a few months. Okay, let's say you happen to be in public and someone's complaining of their heart racing and the paramedics come and they put on electrodes on the chest of the person complaining of their heart racing, and they see this on their little machine. And you see them getting ready to shock. You say to them, oh, you better shock. They're not doing well. And the patient's looking at you with pretty wide eyes saying, you're going to shock me? I guess my question to you is, would we want to shock this or would we not want to shock this? So this is a rhythm, a fast rhythm from the top part of the heart. We know it's from the top because the large wave is narrow. It's a narrow large wave. That means the circuits in the bottom part of the heart are okay, but it's too fast. So that means it's coming from the top part of the heart. The patient's awake and talking to you and feeling okay, just has heart racing. So you never want to shock a patient like that. They won't be happy that you electrocute them. This is a patient you would say, hey, looks like SVT. It's fast. It's from the top of the heart. Why don't you bear down and see if you can break it yourself by bearing down? And a lot of times people can break this themselves, or you can have them come to the ER. Now, we've hit some of the basics of heart rhythm. Things get more complex, especially if a patient comes with heart palpitations and the beta blocker that we've tried to give them is not working, or they continue to have fast heart rhythms. Well, then they need to see a specialized cardiologist called an electrophysiologist. That's a cardiologist that specializes in electricity of the heart. And just to describe what's going on here, usually what electrophysiologists will do is they've studied extra years to understand even better the electricity of the heart, and they can dose complex medications that work on the heart. These are not normal medications in the fact that you can just take them and send someone on their way. They have side effects that actually cause bad heart rhythms, so they need to be monitored closely by an electrophysiologist or a cardiologist that has handled them before. And you can, and that's one of it's kind of an upgrade in medication for heart rhythms. Of course, the main job of an electrophysiologist is what's called an ablation. And it's a procedure done in the cath lab under X-ray, where they put catheters up through the groin inside your heart. Now, you can't see your heart. They, of course, know exactly where your heart is by X-ray. And you put these catheters in. These catheters are special catheters that are picking up the electrical signals on the inside of the heart. And so say you have a patient that has an SVT we talked about, and it's annoying them. It keeps coming back. They can't get rid of themselves. Beta blockers are not working. Well, they can get a simple procedure by an electrophysiologist. He takes this catheter, which is a catheter called an ablation catheter, where in the tip of it he can burn the inside of the heart, just the surface where the electricity runs. So he goes using these specialized catheters that map out the electrical signals in the heart. He can go find that extra beat. Let's see if I have it here. For example, here it's showing the extra beat here. He takes his catheters, comes in from the vessels, finds it, and burns it out from the inside and actually cures the SVT, and it just doesn't come back. It's a pretty remarkable procedure, and they can do some remarkable things. The last question, extra credit question. This rhythm, can it cause a stroke? So the answer is yes, it can. If we look at this rhythm, you may recognize that it's narrow, so we know the big wave is narrow, so we know the bottom part of the heart is okay, but we don't see any T waves, and it's also irregular. It's not a regular rhythm. This is atrial fibrillation, and we talked about atrial fibrillation causing a stroke, and that's what our next webinar is going to be about. Any questions? All right, we appreciate you signing in and listening to us, and take care. Thank you.